Good day. I am tasked to discuss briefly epidemiologic investigation of a disease outbreak. At the end of the session, the students shall be able to, number one, explain the public health relevance of conducting an epidemiologic investigation of a disease outbreak, and second, discuss the basic steps in an epidemiologic investigation of a disease outbreak, including the giving of public health recommendations on curbing or controlling the epidemic. So, truth be told, in our lifetime, we have encountered several epidemics already. The most popular of which, and I think to which most of us will be able to relate to, will be the COVID-19 pandemic, which plagued not just our country, but the entire world during the early part of 2020 until the middle of 2022, 2023. But prior to the COVID-19 pandemic, there were other epidemics that were reported and documented. This will include the MERS-CoV and even the SARS, or the Severe Acute Respiratory Syndrome, during the early 2000s. There are other emerging and re-emerging infectious diseases, including the epidemics related to the bats, for example, the Nipah virus, among other things. And of course, you have your Ebola or even your um, avian influenza. Now, why is it imperative that from a public health perspective, we investigate a disease outbreak? Investigating a disease outbreak would entail multiple advantages and reasons. That will include control and prevention, research opportunities, training opportunities, health program coordinate considerations, and even concerns that would talk about legal aspects or even public and political issues. I will try to go over them very briefly, starting with control and prevention. When we talk of epidemic control, you want to describe the characteristics of the people who are most likely to be infected or to get that epidemic. So we identify and we characterize the most at risk population. In the same vein, not only do we describe and identify the people who are at risk, but the ultimate goal is to prevent development of additional new cases. On the other end, we have prevention of future outbreaks. It is imperative that we identify the source of the initial outbreak so that we will be able to design and institute control measures. The balance between instituting control measures and conducting further investigations will depend on how much the epidemiologic investigator will know about the causative agent, the source of the agent, including its mode of transmission, since one cannot design control measures without this extent of information. Now, from an academic perspective, outbreak investigation will also entail research opportunities. If you're looking for a newly emerging infectious disease, we can characterize the population at risk, we can identify associated risk factors, and if we still don't know yet the natural history of the disease, we can describe the entire clinical spectrum of that illness. However, if we are dealing with a familiar disease already, let's say, for example, when we're talking of a dengue outbreak, sometimes the reason why we investigate is that we will be able to identify new diagnostic technology and laboratory technique. We also identify new therapeutic interventions. And of course, we try to look into how these will impact on the control measures. I'll give an example. Back in the day, we would use to diagnose pulmonary tuberculosis through direct sputum smear microscopy. For our graduates of the College of Medical Technology, I'm sure part of your competencies is that you performed an acid fast bacilli staining, and you tried to identify your Mycobacterium tuberculosis. But with the increase in popularity of your polymerase chain reaction, the way we diagnose tuberculosis is now based on expert or your RT-PCR diagnostics. And if you look at pulmonary tuberculosis as a public health burden in developing countries like the Philippines, then the use of such newer technology would be a good advancement in identifying the needed resources necessary to control such infectious diseases. A disease outbreak or epidemic will provide opportunities to revisit and study natural history of the disease entity, looking into the interaction of the triad of the agent, host, and environment. It also gives training opportunities. Investigating an outbreak will require a combination of diplomacy, logical thinking, problem solving skills, quantitative skills, epidemiological know how, and good clinical judgment. These epidemiologic and public health skills improve with practice and experience. Hence, it is for this reason that when we talk of epidemiologic investigative teams, we would normally see the pairing of a seasoned epidemiologist with an epidemiologist in training who gains valuable on the job training as well as experience while assisting in the investigation and control of the current outbreak. We'll also look into health program considerations. Outbreaks will put public health officials at the position to review current and existing public health programs in terms of, are there newer populations at risk that have been previously overlooked? We recognize any potential failure in the existing program's intervention strategies, and we try to distinguish and identify if there are changes in the etiologic agent that is responsible for the epidemic. We also identify events beyond the scope of the current public health programs. Now, also from another vantage point, from the public, political, or legal perspective, concerns will sometimes override scientific issues in a decision to conduct an investigation. Increasingly, the public has taken an interest in disease clusters and potential environmental exposures and has called upon health departments to investigate. This is quite real given the fact that social media is being utilized as a means of spreading information, whether the information is factually correct or if it's just fake news. But sometimes it is the public that prompts the health authorities to investigate certain possible epidemics. Nevertheless, many health departments have learned that it is essential to be responsibly responsive to public concerns, even if the concern has little scientific basis. And they also see these instances as opportunities to educate the general public. Now, whenever we participate in an outbreak investigation, it is important that we recognize certain characteristics on how do we approach epidemiologic investigation. Speed is critical, but getting right answers is also imperative to ensure that our epidemiologic investigation is technically sound. To satisfy both the speed and the accuracy of information, epidemiologists from the US Centers for Disease Prevention and Control, as well as from the World Health Organization, tried to come up with 10 basic steps in investigating a disease outbreak. Now, I want to be quick in saying that the steps presented in this lecture are in conceptual order. However, I must be quick to say that the steps can occur simultaneously, or they may come in different orders. But what is essential is that these steps are facilitated or carried out throughout the investigations. To investigation, control measures should be implemented the soonest possible time, the moment we are able to identify what is the source of the epidemic, and we also learn of the mode of transmission rather. So when we talk of control measures, depending on the speed of identifying the source and recognizing the main mode of transmission, then control measures may be instituted at the very early stage of the outbreak, or towards the latter part of an outbreak investigation. So what are these 10 steps? Let me go through them one by one, starting with preparing for field work. Before leaving for the field, the epidemiologic investigators should research the disease and gather the needed supplies and equipment, make necessary administrative and personal arrangements for such things as travel. For example, if you are trying to identify, let's say, a meningococcinia outbreak, let's say, for example, in Zamboanga City, it is imperative that before you go to Zamboanga City, you coordinate with the health officials of the entire Zamboanga Peninsula and tell them that you will be going to their area for field work. If there will be necessary permits for you to present prior to investigation, then these will be also taken care of in terms of the preparation for field work. Consult with all parties to determine one's role in the investigation and the local contacts who will be assisting in the investigation once the public health officer arrives on the scene. Or this is where it is important that we recognize the role of networking when we are preparing for any investigative procedure related to a disease outbreak in the field. Important that you know what outfit you should be wearing if this is something that is highly infectious in origin. I want to share with you a story, very funny story that I personally experienced sometime in 2003. I'm not sure if you were born already in 2003, but I was already a duly licensed doctor in 2003. And one of the first jobs that I accepted or I took was that of being the general physician at the Department of Foreign Affairs. So one day I received a call from one of the personnel at the DFA informing me that um they were handling an OFW who just returned from Hong Kong, if I remember correctly. So she was a domestic helper in Hong Kong, and she was presenting with fever. At that time, we were still monitoring the SARS epidemic. That's the severe acute respiratory syndrome. And I was so ignorant of public health back then as a newly licensed doctor. So I remember sometime in June, there was an initial report of the first SARS suspect in the Philippines. And I was being called to examine that woman who just came from Hong Kong. At the back of my mind, I was thinking of the fame and the glory that I will be getting if I were the doctor who first examined a patient, the first case of SARS in the Philippines. So that was what was running inside my head back then. And I remember I went down from my clinic, I went down to the first floor at the gym where the woman was waiting, and I examined her. And then I was very proud that I alerted the Department of Health and I told them, oh, I am from the Department of Foreign Affairs and we have a patient suspected of having SARS. And then the DOH personnel told me, Doctor, kindly wait with the patient and we will pick up the patient and bring her to our facilities. So as a very um diligent doctor, I followed the instructions. So I sat down beside we were waiting for the ambulance to conduct the OFW from the DFA in Pasay all the way to Manila in the Department of Health. And I was chit chatting with the girl. So I was seated next to her. We were chit chatting, doing small talk. And then all of a sudden, I hear the ambulance. And then when I heard the ambulance coming, I was delighted that finally the people were all here. And then to my surprise, when all the people inside the ambulance came down, they were wearing level 4 PPEs. And it was the first time in my entire life that I have seen PPEs of this caliber back in 2003. And I was so shocked thinking that, oh my God, this is the first possible SARS patient. And I did not realize that I was in direct contact with that girl for a couple of minutes and I wasn't wearing any PPE. And it was a bad learning experience for me, putting myself at risk. And then when the DOH personnel all came, they lit in this level 4 PPE. They picked up the lady, put her inside the ambulance, and they left, leaving me all alone in the gym. And in my head, I was running, oh my God, how stupid of me. What if she turns out to be positive for SARS and I was exposed to her? I was literally a few inches away from her. And throughout that time of waiting, of whether or not, so in my initially, I wanted her to be, oh God, please make her the first SARS patient of the Philippines. And then my prayer suddenly shifted to, oh God, oh God, oh God, please make her negative. Because if she turns out positive, then I would have been exposed to SARS, not knowing that I should have worn level 4 PPE. That's the problem if you are not familiar with proper field work. So, an anecdote that I want to share with you, and I want you to learn from my mistakes. And back then, since then, I started to be more cautious of how to deal with people of possible infectious, with having possible infections that are highly contagious. So, part of the field work, know what to wear when you are to investigate a disease outbreak. Then you have to determine whether or not this is indeed an outbreak. Sometimes there could be a suspected outbreak, but it is not real. So, how will we know if what is real or what is not real? Some will turn out to be true outbreaks with a common cause. Some will be unrelated cases of the same disease, and others will turn out to be unrelated cases of similar but unrelated diseases. Before deciding whether an outbreak truly exists, one must first determine the expected number of cases for the area in the given time frame. I want you to recall the concept of the sporadic, endemic, epidemic, and pandemic. When we're talking of an endemic disease, as a review, these are cases with high occurrences in certain areas, which could be the norm for that area, but not necessarily seen in other regions. For example, when I say malaria is endemic in Palawan or in the Rizal province, it will not be surprising if you see a patient with malaria coming from these regions. But if I say, oh, there is a single case of malaria in Metro Manila, because Metro Manila is not known to harbor the malarial parasite, that already becomes an outbreak. So even just a single case could be defined as an outbreak if it is not commonly encountered. Another example, meningococcemia is a fast, fatal infection. Once we see a patient who is suspected or diagnosed with meningococcemia, even just one patient at the emergency room, everyone in the emergency room, the doctors, the nurses, the janitors, the other patients, the other bantays of the patients, everyone who was exposed to that single patient will require prophylactic regimen against meningococcemia because it's very fatal. So when we say epidemic, the epidemic will refer to a sudden increase in the number of cases beyond what is the usual trend or the usual level. Now, when epidemics occur simultaneously in multiple WHO regions, then that is what we refer to as the pandemic. So, how do we know if an outbreak truly exists or not? Usually, one can compare the current number of cases with the number from the previous weeks or months, or from comparable periods during the previous few years. Or you can look into sources of data. For example, if we are alerted by, let's say, certain notifiable diseases, then even just a single case would allow us to be more um, critical in assessing whether or not an outbreak truly exists. Other diseases and conditions can also come from hospital discharge records, or if you review existing registries, including mortality records, or if the local data are not available, you can make estimates using data from neighboring states or national data, or one might consider conducting phone interviews of doctors who might have already encountered similar cases. Even if the current number of reported cases will exceed the expected, not all will mean an outbreak truly exists. When will this happen? If there will be changes in the way we report certain condition, changes in local reporting procedures, revisions in our operational case definitions, increased interest because of local or national awareness, or improvements in diagnostic procedures. Again, when I was a resident at the Philippine General Hospital, when we talk of dengue, we would normally rely on hematocrit and hemoglobin determination while looking into presence or absence of leukocytosis and or leukopenia together with some thrombocytopenia and or thrombocytosis. So this has changed significantly with the introduction of the dengue NS1 and the dengue IgM IgG, which are rapid diagnostic tests. So if in the past you would wait for 2 to 3 days to confirm presence or absence of dengue, now in just a couple of hours, you can already categorically diagnose dengue using dengue NS1 IgM IgG. So the use of the rapid diagnostic tests can somewhat increase the number of new cases because of the rapid assessment that it confers. Other factors may come into play, including, for example, severity of the illness, the potential for spread, seasonal populational changes, political considerations, public relations, and the availability of resources. Then we also have to verify the diagnosis. One must identify accurately as possible what the true nature of the disease. When we talk of the proper diagnosis, it will entail that we are ensuring that the problem has been properly diagnosed, and for outbreaks involving infectious or toxic chemical agents, one must be certain that the increase in diagnosed cases is not the result of a mistake in the laboratory. I'll just give you again an example of what happened from 2020 to 2023. I remember when we were first looking into COVID-19 testing, one of the first things that they were trying to identify is the presence and absence of the antibodies. Antibodies will be an indirect assessment as a compensatory mechanism of the body to respond to the presence of an antigen. So initially, when we were doing COVID-19 testing at the medical city, we were just looking into antibody determination. Then it involved a higher type of rapid diagnostic tests wherein we were doing antigen testing. And this was very fast. I remember in antigen with antibody testing, if you recall what happened in the early 2020s, when you are suspected to have COVID, you were required to be in isolation and or quarantine for 14 days. And after the testing, you wait for a couple of days for the results to come out. So during that interim, while we're waiting for the results, for the next 72 hours, you are having anxiety attacks. Do I have COVID or not? Then we had the introduction of the rapid antigen testing, wherein the results are now looking for certain proteins, and that we were able to identify if an antigen was present or not. Now, with newer technology, with the use of your polymerase chain reaction, we were able to isolate DNA material, even just a small portion, to really identify the COVID-19 virus in your body. And so the evolution of the testing also contributed to the way we diagnose COVID during the pandemic. We define the cases. It is imperative that we have case definitions. And when I say case definition, it would include four components: the clinical information about the disease, the characteristics about people who are most commonly affected, information about the location or place of where the infection could have happened, and a specification of time during which the outbreak occurred. Now, one should base the clinical criteria on simple and objective measures in terms of time characteristics. The criterion might be onset of illness within a with a specified temporal interval. For place characteristics, there could be specific geographical areas where there would be clustering of the cases. Whatever the diagnostic criteria set, one must apply them consistently and without bias to all the people included in the investigation. Ideally, the case definition should be broad enough to include most, if not all, of the actual cases without capturing what are called your false positive patients or cases. And then we use terminologies including confirmed, probable, and possible cases. And I'll let you read on the operational definition of all of these. If you go back as of December 2020, when we were slowly dealing with COVID-19, the World Health Organization came out with various definitions of the COVID-2 infection. They defined operationally what is a suspected case versus a probable case versus a confirmed case. So again, when we talk of case definitions, we have to be very particular and specific. We also do surveillance. We try to identify the people who are at risk or who have been exposed. And sometimes we alert media, local medias, to properly disseminate the information to the general public. I am unsure if you still remember that fateful day of January 30, 2020, when then Secretary of Health Francisco Duque III categorically confirmed that the back then we call it the novel corona virus of 2019 and COVID 2019. And we wanted to make sure that if the outbreak affects a population, you may want to conduct a survey of the entire population. Now, sometimes we also use a questionnaire to determine the true occurrence of clinical symptoms. Let's say, for example, in the operational definition of COVID-19 of the WHO, you want to collect clinical data, or you can actually do laboratory specimen collection. And we also do contact tracing as part of our initiatives to control the infection. Traditionally, epidemiologists collect the pertinent information in standard case report form, the questionnaire, and the data abstraction form. So I shared with you my story of 2003 when I first encountered SARS. Now, fast forward to 2020. I remember, so I hear January 30, 2020, Francisco Duque announced that the COVID-19, the novel coronavirus of 2019, has successfully entered the Philippines. 2 days later, I think February 2, if I recall correctly, while holding clinic at the medical city, a patient comes presenting with fever, and this patient was now a businesswoman coming from, if I remember correctly, from Guangzhou, China. And suddenly I was petrified in a way because I was having deja vu of what happened during the SARS, and I was the first doctor at our clinic at the medical city in SM Marikina to entertain a possible COVID-19 patient. And remember, at the peak of this, at the start of the COVID-19, we identified patient number one, number two, number three. Remember, there were memes that I am number one, I am number four, because we were documenting the first few cases. So when I received a suspect, I had to call the PIDS R. And I remember it was around, my clinic would end supposedly at 7 o'clock. This patient came around 6:15. And I was calling the RITM, the Research Institute for Tropical Medicine, getting guidance on what to do. And then they sent to us via email the case investigation form for COVID-19. And I remember my hands were shaking when I was accomplishing this form because I was thinking, oh my God, oh my God, oh my God, let this patient be not COVID-19, because I was again exposed to her and I didn't want to be one of the first few to be placed on community quarantine. And if you look at this survey, it would include several information. I remember this is a back-to-back, if I remember correctly, this is a back-to-back form, and this would include data looking into identifying information, demographic characteristics of the study subject, um, clinical information of the patient, risk factor information, as well as data coming about me, the reporter information. And it was very nerve-wracking because you again had to wait for the DOH to tell you what to do next. So I remember making that fateful call, and we had to wait for the DOH to pick up again the patient, transport her from Marikina all the way to the RESU, the Regional Epidemiologic and Surveillance Unit, somewhere I think in Pasig, if I not if I am not mistaken. So just to give you an idea of what the case surveillance forms would normally look for or report. Now you also describe the outbreak in terms of time, place, and person variable. So again, this is part of your descriptive epidemiology. You characterize the outbreak in terms of these variables. You look at the trend over time. You look into compare places where people have most probably have been exposed to, and you look at the population at risk. We also try to identify sources of infection, modes of transmission, recognizable risk factors, and all of these would be utilized to come up with possible hypothesis of causation. So one of the things that we use when we try to characterize the epidemic according to time variables will be the epidemic curve. Traditionally, public health investigators and epidemiologists show the time course of an epidemic by showing a graph of the number of cases by their date of onset. This graph, which we call your epi curve, is a visual display of the outbreak's magnitude and temporal trend. And the epidemic curve provides information looking into the course of the epidemic and possibly to project its future behavior. It can be utilized to establish probable incubation period and identify or estimate the logical time period of exposure. And lastly, it may draw inferences about the epidemic pattern. For example, are we dealing with a common source exposure, or is there person to person transmission, or both? Now, the epi curve can also be utilized to estimate two important characteristics: the probable incubation period and the period of exposure. If the timing of the presumed exposure is known, epidemic curves can be used to estimate the incubation period of the disease, and this may facilitate the identification of the causative agent. This is because the period between the known or hypothesized exposure time and the peak of the epidemic curve represents the hypothesis median incubation period. Now let's pretend if the etiologic agent is known, and therefore both the incubation period and the median incubation period are also readily identified, then we can estimate the date of exposure. Normally, let's say, for example, if you plot, let's say, cases, for example, there is a new outbreak, and you noted that the peak incidence was reported last March 13, 2026. If the etiologic pathogen is known, and let's say the given median incubation period is 9 days, then we can determine that the date of possible exposure would be somewhat around March 4. And how did we derive this? The date of incidence peak minus the mean incubation period. So you come up with March 4. If you have a tracing paper or a graph and you try to plot the number of cases on the y-axis versus time, and let's say, for example, this is the peak of occurrence, let's say March 13, but you know from existing literature that the incubation period should be somewhere, let's say, for 3 to 14 days. And how do we determine the incubation? I'm sorry, 9 days. And then how do you determine the date of exposure? Again, you simply subtract the peak with the incubation period. Now, what if the range of the incubation period is already known because the etiologic pathogen has been identified accordingly? Then you can also determine the exposure period. This is the start of the epidemic symptoms. Then you subtract the minimum incubation period and you look at the date of the last reported case and you subtract the maximum incubation period. So, for example, if you know for a fact that the incubation period of a known pathogen is somewhere around 5 to 14 days, and the first case was documented, let's say, at March 7th, and the last case was reported on March 18th. So, if we are to calculate the incubation period, it would be from 5 to 14 days. First date is March 7 minus 5, the lower limit. That would give you March 2. And the last documented case, March 18. So minus the maximum incubation period, March 4. So the exposure period should be somewhere from March 2 to March 4. So again, if this were your graph, so March 7 is the date that the first reported case was documented. So the first day minus the lower limit of the incubation period, which is 5 days, that will give you March 2. And if you look at the other end, March 18, the date of the last reported case, minus the lower limit, or the longer upper limit rather, of your incubation period, which is 14 days, and that will give you March 4. So the exposure period is sometime from March 2 to 4, several days before the first documented case was reported. The epi curve can have various appearances, and you can, if you eyeball the type of epidemic curve that you generate, then you can identify epidemics with the point source epidemic, common continuous source, common intermittent source, or even propagated source. So again, for your review, I'll just ask you to go over these epidemic curves. If you want to do supplemental readings on these, then you can do so. Then we characterize by place. Assessment of an epidemic by place provides data on the geographic extension of a problem, and may also show clusters or patterns that provide clues to the identity and origins of the problem. A simple and useful technique for looking at geographic patterns will be to utilize a spot map of the area where the affected people live, work, or may have been exposed, are plotted. So this is an old spot map at the peak of a dengue outbreak in the Philippines sometime in 2019. So again, the spot map is a visual representation of what an epidemic may potentially look like. Then we characterize according to person. We look at the most at-risk population. Often we look at personal characteristics, possible exposure variables, and these are the things that would be that would come into play when we talk of susceptibility to the disease and to opportunities for exposure. Usually, age and sex are the first two characteristics that are looked into in terms of characterizing an outbreak, but sometimes there will be more specific variables or characteristics that would be suggestive of a disease, and this is where the setting of an outbreak may become very useful. Then we develop hypothesis of causation. In real life, epidemiologic investigators usually begin to generate hypotheses to explain why and how the outbreak occurred when we first learn about the problem. The hypothesis should address the source of the agent, the mode of transmission, and the exposures that cause the disease. Just like in any epidemiologic research, the hypothesis that we generate should be tested to see if it's true. And how do we evaluate the hypothesis? We look into the credibility of the in epidemiologic investigators' hypothesis. You can look into relating the current hypothesis to already existing facts, or you can look into other ways to test your hypothesis of causation. For example, if you are dealing with a cohort study, determination of the risk ratio could tell you if there is association between risk factors and the outcome of interest. If you're dealing with a retrospective study design, then a case control study would yield your odds ratio. Let's look into the origins of nCoV or your COVID-19. If you look at the previous influenza related epidemics during the year 2000, when we had SARS, we knew that the coronavirus originated from the bats. Somehow, the migratory bats transferred the coronavirus to the civet cat, which then transferred it to humans. Then, fast forward to 2012, the bat now carried the coronavirus to the camel, and the camel eventually caused the MERS-CoV in Africa, and this also resulted in another pandemic. During 2019, initially, there were many theories as to how the coronavirus could have possibly been transmitted either to the pangolin or the anteater or to a snake. And they initially thought these were the main animal hosts that harbored the nCoV. But after several years, so this was in 2019, when they first hypothesized that the coronavirus emanated from the pangolin or from the snakes. Eventually, fast forward to 2023, there are now data to suggest that the COVID-19 indeed started from the raccoon dogs. So you see how over time hypothesis will change based on newly acquired information or data. Now, what about foodborne outbreaks? So a special type of hypothesis testing could be used. Let's say, for example, if you are entertaining a possible food poisoning event, what we normally do from an epidemiologic perspective is we list down all the food items that you suspect that could potentially cause a foodborne outbreak. And then you look at people who ate the specific food items and those people who did not eat those specific food items. And then you try to plot it who developed the illness, how many did not. For example, let's look into the baked ham. If you look at the data for baked ham alone, we can determine the attack rate for both the population who consumed the ham and the attack rate for those who did not eat the ham. From this data, you can now determine your risk ratio. So if you look at the data and I plot all the attack rates for those people who consume the various food items, and I also determine the attack rate of those people who got sick but did not eat the food item, I will be now able to determine the risk ratio. So, for example, how did I get this? 29 over 46 will give you 63% for baked ham. 17 divided by 29 will give you 59%. And 63 divided by 59 will yield a risk ratio of 1.07. And you can do this down the column, complete the table, and notice that the vanilla ice cream has the highest risk ratio. And so, from a logical perspective, because this is the item with the highest risk ratio among the different food items, I would most probably point my finger at ice cream as the vanilla ice cream as the main culprit that precipitated the foodborne outbreak. Now, we also always test for statistical significance. Maybe when you go to higher biostatistics, we will go back to this, but just be mindful right now that when we talk of statistical significance, we can look into the p-value, and this is how we determine whether or not the relationship, let's say the the attack rates or the risk ratios are statistically significant or not. So again, just to review, these are the general schema of a case control study versus a cohort study. And from this, you determine the main measure of association. If we're dealing with case control studies, your case control studies will yield your odds ratio, while your cohort study will determine the relative risk or the risk ratio. So if the p-value is less than 0.05, then you can be sure that it is statistically significant and that the relationship truly exists and it's not merely due to chance. So I've mentioned this already. So again, I'll just let you read over these um parts of this lecture slide deck. Now, once you have tested the hypothesis, why do we need to do more epidemiologic studies? We need to do more research if you want to refine your hypothesis, and so you carry out additional studies. When analytic epidemiological studies do not confirm hypothesis, one may need to reconsider the hypothesis and look for new modes of transmission by doing more epidemiologic research. Now, this is the most opportune time to meet with case patients to look for common links and possibly refine the probable hypothesis of causation. Now, what would happen if we took the advice of an poorly misinformed senator who once said na bakit daw kailangan mag-research? Bakit ba daw baliw na baliw ang mga academicians sa research? Kung walang research, we will not be able to uh, look into further uh, robust epidemiologic data to answer our inquiries. When an outbreak occurs, it is routine or unusual. When an outbreak occurs, whether it is routine or unusual, one must consider what questions remain unanswered about the disease and what kind of epidemiologic research one might use in a particular setting to answer some of these questions. So we do more research and we do not take the advice of this um, a bit illogical senator who once said na hindi kailangan ng research. Of course, we do need research, especially in the case of outbreak investigations, because we need to have more data about the disease, the transmission, characteristics of both the agents and the host. So we need to also have laboratory evidence, environmental study. Now imagine if the epidemiologists did not do further research, then we wouldn't have been vaccinated. We wouldn't have successfully address the COVID-19 pandemic if there was no research done. Then we implement preventive measures. Normally, implementing public lectures may be done at any stage of the epidemic, whether it's at the start, as long as you already know the source of the disease, you can initiate control measures aimed to minimize or break the links of the chain of infection that would address the agent, the host, and the reservoir relationship. You want to reduce susceptibility. I refer you back to the breaking the chain of infection, and it's important that you understand why different public health measures have been initiated or have been implemented in the overall control of an outbreak investigation. Even the use of contact tracing, quarantine, and isolations, these are all necessary strategies to control an epidemic. And of course, the vaccination, including the boosters. So imagine if we did not do the research and we wouldn't have received the vaccines or even have known recommendations on how to address the epidemic. I remember the start of the epidemic, there were many drugs which allegedly would curb the COVID-19 pandemic. There were anecdotal, unfounded data that supported the use of ivermectin, hydroxychloroquine, azithromycin. So overall, from epidemiologic research, we were able to debunk such information, and the most important public health measure that we were able to provide the public was the vaccination campaign, including the booster doses. We also do active surveillance. This is part of the monitoring and evaluation. And it's imperative that as long as there is a possible still transmission, community transmission, we actively do surveillance and do case reporting as well as case notification. In terms of active surveillance, the reasons for conducting active surveillance, so you want to know whether or not your current measures are working, and you want to know if there will be other areas where newer areas where the epidemic has moved into, or you look into other parameters. I want to give a brief discussion on the R naught and the reproductive number. So the R, or the reproduction number, is it quantifies the capacity of an infectious agent to be transmitted. The R number signifies the number of individuals that one sick patient will successfully pass the infectious agent to, while the R naught refers to the infectious agent's transmission rate within any given population with no established immunity against the pathogen. So again, assuming yung mga anti-vaxxers, mga hindi nagpabakuna. So if you look at the R naught is not fixed. And over time, it changes based on the virulence and infectivity, the population dynamics. Location is also pivotal when it comes to looking into the R. You expect the R to be higher, or the reproduction number to be higher in more densely populated areas. Now, if you look at the R naught, an R of 1 and above would tend towards exponential growth, while an R of below 1 would suggest that we are nearing the end of the outbreak. So let's look at the R. If you look at, let me go back here. So I want to again say here that if the R is the less an R of below 1 tends towards the end of the outbreak. Towards the latter part of the administration of Rodrigo Roa Duterte, in 2023, they said maybe we should stop monitoring the daily R naught and all that. But if you look at this, this was published sometime in June 2022, our R was still around 1.08, still not below 1. And you look at the cumulative positivity rate of 13.5% when the monitoring of the COVID-19 stopped in April of 2023. Now, what does this tell us? If you look at the data from the Johns Hopkins Bloomberg School of Public Health, they said that if the percent, as a rule of thumb, one threshold for the person positive being too high is 5%. For example, the World Health Organization recommended in May that the percent positive remain below 5% for at least 2 consecutive weeks before governments consider reopening their economy. At the time that this was released, and back in 2023, our positivity rate was still 6.5, and yet we started to open the malls. People were already traveling to other parts of the globe as if the pandemic already stopped or has already ended. People were going to the beach, but look at the recommendation, 5% below for at least 2 consecutive weeks. And when we reopened everything under the Duterte administration, our positivity rate was still 6.5%. Compare that from the previous 13.5% in April 13, 2023 to April 11. Look at the increase. So April 11, 6.5 according to Okta, then according to DOH, April 13.5% positivity. So just to give you a glimpse of how our government back then addressed the COVID-19 pandemic. Was the government successful? You be the judge, but I'm presenting to you the data. Now, it's also imperative to alleviate or allay the anxiety of the general public. You also want to communicate findings of your epidemiologic investigation. So, the last task of the team is to effectively cascade the findings of a study to all relevant stakeholders. There could be oral briefing or there could be a written report. Now, it's important that if we have effective communication skills. The oral briefing must be attended by local health authorities and the stakeholders designated to implement prevention and control measures. This is an opportunity for the investigators to describe what has been done so far, what has been found, and what they theorize should be done still in the future. It must be done in a scientifically objective fashion wherein we only provide evidence based recommendation. Now, most importantly, we have to state conclusions and recommendations with finality based on technically sound research methodology. Imagine if the highest government official tells you to just disinfect using gasoline. And when you communicate something to the general public, you should never interject nonsensical suggestions that are barely based on one's non humorous or even irrational personal opinion or viewpoint, especially when there is an ongoing public health crisis, more so a global pandemic. Imagine listening to the highest authority in the Philippines telling the people, no joke, gumamit kayo ng gasolina. Imagine that. What image are you projecting if this is how our government addresses the public health issue? A written report is more scientifically written. It would include several parts. It's a blueprint of a definitive plan, and it will likewise serve as a record performance, a documentation of potential legal issues, and a standard reference for the future in the event that there would be similar epidemics. It likewise contributes to the scientific knowledge base of epidemiology and public health. In recent years, the public has become more aware of and interested in public health, and sometimes the health departments the health department must be able to adequately inform the public so that we allay all anxieties or fear. Many health departments communicate directly with public using various forms of media, whether we're talking of the newsprint, television, radio, or even the internet and social media. Perhaps this is my last contribution to the growing pandemic. I remember being interviewed by Yahoo Philippines sometime in August 2021. In fact, when they were interviewing me, I was actually having the Delta COVID-19 back then, no? And it's imperative that you understand how we control the epidemic, not just from a clinical perspective, but even from the public health lens. And that is why we try to champion holistic, patient-centered, family-focused, community-oriented approach to the COVID-19 pandemic. So just wanted to share these. Again, I am not 100% an expert when it comes to epidemiologic outbreak investigations, but I am sharing with you the technical steps on how to go about dealing with an epidemic. Disease outbreaks may occur frequently and are always unexpected events. And the most important reasons to investigate is to learn enough about the situation for us to implement appropriate control and preventive measures. We also take the investigation as opportunity to advance knowledge about the disease, the causative agent, identify risk factors, look into interventions and other scientific issues. We respond to public, political, legal concerns. We look into programs' effectiveness and weaknesses, and we provide opportunities for training for those in the field of public health and epidemiology and or tropical medicine. Disease outbreaks and epidemics are the subject of media attention and public concern, so investigators feel pressured to work quickly to find answers when multiple agencies, stakeholders, sectors are involved. Coordination, communication are critical, and it is essential to have a systematic plan for conducting the investigation. I want to refer you to this particular handbook that we normally use in investigating an outbreak. This was one of the first few shots that I had when I was in the medical city as a frontliner for COVID. I received this card from a grade, I can't remember, grade 5 or grade 4 student from Xavier because I was treating his family for COVID, and he sent me this memorable thank you card. He drew that for me. Just wanted to say that the COVID-19 pandemic was something that I don't want to happen again, but it gives us opportunity to really look into the proper way of collaborating and maximizing resources to address this public health burden. So, with that, I thank you for your kind attention. I know this lecture is a bit long, but I hope you learned something from the lecture. Please do check Canvas. I included a specific exercise that will further deepen your understanding of outbreak investigation. If you have questions, I'll be more than willing to answer them. Hopefully, I will be competent enough to address your concerns on our next session. So, with that, thank you and good day to everyone. And I hope to see you in school soon.